Hey everyone, and welcome. Today, we're doing a deep dive into a condition you deal with at the pharmacy counter all the time, gout. From helping someone through that first agonizing flare-up to counseling on a new allopurinol script, it's a huge part of our practice. So consider this your clinical refresher on the latest, most practical tips for managing it. Let's get right into it.
So, here's our game plan. We're going to follow the patient's entire experience, starting with the 4 stages of the disease. Then we'll tackle how to handle that acute, super painful flare. After that, we'll shift gears to the long-term strategy with urate-lowering therapy. And we'll wrap it all up with the most important counseling points you can start using with your patients tomorrow.
First things first, let's just get on the same page with the definition. It's really important to remember that gout is so much more than just a type of arthritis. It's actually a systemic disease, and it's all caused by these tiny monosodium urate crystals building up in the body. These little crystals are the real bad guys, causing not only that intense joint inflammation, but also forming these nodules called tophi and even damaging the kidneys over time.
Now, this disease usually progresses through 4 pretty distinct stages. It all starts with what we call asymptomatic hyperuricemia, basically high urate levels in the blood, but no symptoms yet. Then, bam, you get the acute gouty flare, that classic can't even put a sheet on it pain. The quiet time between attacks, that's intercritical gout. And if things go unmanaged, it can eventually lead to chronic tophaceous gout. This framework is going to be our roadmap for this whole talk.
Okay, so picture this. A patient comes into your pharmacy. They're limping, they can barely walk, and they're describing a joint that feels like it's literally on fire. They are deep in an acute flare. Our #1 job is to help put that fire out. And for these treatments to work best, they really need to be started within 24 hours of the flare starting.
So, we've got 3 main tools in our first-line toolkit. First up is colchicine. It works fast, which is great, but it's notorious for those GI side effects. Then you've got your NSAIDs. The workhorses for pain relief, but we always have to think about the GI and cardiovascular risks. And finally, we have corticosteroids, a really potent option and super useful when the other 2 just aren't a good fit for the patient.
Let's talk about colchicine dosing for a minute, because this is a really big practice update. A lot of us were taught the old-school dose until you get diarrhea method. Well, that is officially history. The modern way to do it is way safer and just as effective. 1.2 milligrams right at the first sign of a flare, followed by 0.6 milligrams an hour later. That's it. That's a critical counseling point that's going to save your patients a whole lot of unnecessary misery.
And when we look at NSAIDs, you'll notice the starting doses are pretty aggressive. You have to hit it hard to get a flare under control. For something like celecoxib, you'll probably want to think about adding a PPI for anyone with GI risk. With indomethacin, the big thing to watch for is CNS side effects, like dizziness, especially in your older patients. And for naproxen, the key is just to steer clear of it in patients with major CV risk factors or heart failure.
Okay, this right here might be one of the most important things you can tell a patient. During a flare, their first instinct is often to stop their allopurinol, thinking it's causing the problem or just not working. You have to tell them, do not stop. Stopping or changing the dose can actually make the attack worse or drag it out even longer. They need to power through and keep taking their urate-lowering therapy right through the flare.
All right, we've put out the fire, now it's time to think about the long game, so this doesn't keep happening. And that means urate-lowering therapy, or ULT. This is where we make the crucial shift from just managing symptoms to actually treating the root cause of the problem, the high uric acid itself.
And that brings us to a really important clinical question. We don't just put every single patient on ULT after their very first attack. So who's the right person for lifelong therapy? When do we pull that trigger?
Well, who gets lifelong therapy? The 2020 American College of Rheumatology guidelines give us a really clear checklist. You should be strongly recommending ULT if a patient has any tophi, if they're getting 2 or more flares a year, if there's any sign of joint damage on an X-ray, or if they also have moderate to severe chronic kidney disease. This really helps us target the folks who need it most.
The philosophy behind modern gout management is all about this idea of treat to target. We're not just trying to make them feel better. We are actively trying to drive that serum urate level down below 360 micromoles per liter. So why that specific number? Because that's the magic level where the urate crystals that are already deposited in their joints and tissues will actually start to dissolve. That's how you prevent future flares and stop joint damage.
And what's the first-line agent to get us to that target? It's allopurinol. The guidelines couldn't be clearer. It's the go-to starting drug for pretty much everyone, and that even includes patients with chronic kidney disease. We just have to be smart and start them on a lower dose.
Of course, anytime we talk about allopurinol, we have to talk about the rare but very severe allopurinol hypersensitivity syndrome. So the key risk factors you need to be screening for are starting with too high of a dose, any renal impairment, if they're also taking a thiazide diuretic, and in some populations, the presence of the HLA B5801 gene. The single most important counseling point here is to tell your patient that if they get any new rash, they need to report it immediately.
So what about the other big player, febucoxistat? Well, there's a major safety concern here, and it's why it's not a first-line drug. Both the FDA and Health Canada have issued warnings because a big trial found a significantly increased risk of cardiovascular death and death from any cause when compared to allopurinol. This is a huge deal, and it means febucoxistat should really only be for patients who can't tolerate allopurinol or who fail it.
Okay, for our last section, let's pull all of this together and focus on the practical, real-world counseling points for chronic gout management that you'll use every day.
Now here's a weird thing that happens. When you start someone on allopurinol, their urate level drops, which is what we want. But that change can actually stir up the existing crystals and trigger a brand new gout flare. We call it a mobilization flare. To stop this from happening, it is absolutely crucial to start them on a prophylactic anti-inflammatory, like a low-dose colchicine or an NSAID, at the exact same time you start the ULT. And they need to keep taking it for at least 3 to 6 months.
And since we use colchicine for both acute flares and for prophylaxis, we really have to be experts on its drug interactions. I mean, some of these are really dangerous. Interactions with strong CYP3A4 inhibitors, like clarithromycin, can lead to fatal colchicine toxicity. P-glycoprotein inhibitors are a problem too. And you absolutely have to counsel patients on the increased risk of muscle problems when it's combined with a statin. Tell them to report any new muscle pain right away.
And of course, lifestyle advice is a key part of the whole package. The big ones are limiting alcohol, especially beer, cutting back on high purine foods like organ meats and shellfish, and avoiding sugary drinks with high fructose corn syrup. But it's so important to frame this as something that supports the medication, not something that replaces it. For most people, lifestyle changes alone just aren't going to be enough.
So why is all this long-term management so important? To prevent this, chronic tophaceous gout. This is the really devastating end stage of untreated disease. You get these tophi that cause permanent, deforming joint destruction. This is the outcome we are all working so hard to avoid. And the best part is, it's almost entirely preventable with good, consistent, urate-lowering therapy.
So if you only walk away with 5 key messages to bring back to your practice, make it these. Number 1, USLT is for life, so adherence is key. 2, do not stop USLT during a flare. 3, always expect to start prophylaxis when initiating USLT. 4, that allopurinol rash is a potential medical emergency. And 5, lifestyle changes are great, but they support the treatment. They don't replace it.
I'll leave you with this one last thought. As pharmacists, we're in the perfect spot to help shift our patients' perspective. Is our goal just putting out fires every time they get a flare? Or are we going to embrace this modern approach of treating to the target, of actually dissolving the underlying crystals and fundamentally changing the course of their disease for good? Thanks so much for listening.